Morning, everybody. Today I will be talking on placental transfusion, delayed cord clamping, and umbilical cord milking. So we all know that delayed cord clamping is not a new thing. It's an old wine in a new bottle, because in 1801, Darwin had stated that another thing very injurious to child is the tying, and cutting of the navel string too soon, which should always be left till the child has not only repeatedly breathed, but also till all the pulsation of the cord ceases. Because if you don't do that, the child is much weaker than it is ought to be, and portion of the blood being left in the placenta, which is ought to have been in the child. So if we are not allowing that to happen, this will be equivalent to 500 ml of adult bleeding. That was told by Dr. Marsh in 1942. So we know that we already knew about it. However, in 2011, Farrar et al. Defined as amount of blood that flows from placenta to the infant at birth. And increasing the fetal hemoglobin by placental transfusion is an extremely effective method of enhancing the arterial oxygen content, increasing the cardiac output, and improving the oxygen delivery. Now, when we want to adequately transfer the gases which are required for the breathing, then the infant needs 50% of his cardiac output, which should go to the lungs. But what's happening in utero, only 10% of it is going to the lungs. So the placental transfusion would rapidly create this increase in circulatory bed in the lungs, which will help the gaseous transfusion to occur. Now, if we look at the preterm and the term baby, there is a difference because in the preterm baby, the placenta constitutes around 3/4 and the blood unit in the placenta is in 3/4 and fetus has 1/4. What happens in the term baby, this actually is half and half. So that means that more circulating volume is present in the fetus in term baby with advancing age and less in a preterm baby. So we should be very much aware on that part. Now the factors which determine the placental transfusion, the one factor is uterine contraction, which will have placental vesicular pressure of 50 to 100 millimeter of mercury. The other is spasm of the umbilical artery, reducing the flow back to the placenta. And third would be the timing of the cord clamping, because more you will allow this to happen, the more blood is going to come in. Fourth is spontaneous respiration will cause negative intrathoracic pressure. And the last is the gravity. So if you keep the baby much higher on, the blood will go less. So the lower the baby or near the baby to the introitus, the flow is going to be better. Now, this is going to be very much important for the pulmonary veins, arteries to get more blood, increase myelin in the brain, and increase ferritin in the baby. So the effect of the timing of the cord clamping on the placental transfusion are: mean placental transfusion volume is estimated to be around 24 to 32 ml per kg, or nearly 30 to 40% of the blood volume. So if you do an immediate cord clamping, 30% of the fetal placental blood would still remain in the placenta. And if you delay the cord clamping by 60 seconds, then 20% of the feto-placental blood remains in the placenta. And if you make it 3 to 5 minutes, then 13% of the feto-placental blood would remain in the placenta. So you can see that the timing is also very, very important. So what has happened, if you can see the placenta, if you cord clamp early, placenta will look red, baby will look pale. and if you keep on delaying it, placenta will be pale and the baby would be pink. So in 1 minute, 2 minutes, 3 minutes, 4 minutes, 3 to 4 minutes, the baby will be totally pink and red. So 90% of the blood volume transfer was achieved within the first few breaths. However, for the complete thing, it takes time. Now, the spontaneous respiration. So when the baby is breathing and crying, what it does, it will create a negative intrathoracic pressure. And by this, there will be increase in the gradient between the placental vasculature and the fetus. So this will cause increasing transfusion from placenta to the fetus. So if you have a strong uterine contraction, then the role of this spontaneous breathing and crying would be not that great. But if you don't have a strong uterine contraction, the role of this breathing and crying is much important. And therefore, if you have an elective cesarean where you don't have the uterine contractions, so spontaneous respiration has a very important role to play for this placental transfusion to occur. And unlike spontaneous respiration, if you're giving a positive pressure ventilation by bag and mask or bag and tube or TPs, it will not lead to the same kind of an increase in the pressure. And if you are doing an immediate cord clamping before the onset of this spontaneous respiration, it may adversely affect the cerebral perfusion. And if the cord clamping precedes the respiration onset, it will reduce the preload, it will reduce the left ventricular output, and it will reduce the cerebral blood flow. So this is very, very important. The spontaneous respiration and the cord clamping relationship has to be seen. So what are the methods of placental transfusion? Either you can delay the cord clamping or you can do the umbilical cord milking. Now, umbilical cord milking can be done in two ways. You can do the umbilical cord milking in the intact cord, which is intact umbilical cord milking, or you can cut the umbilical cord long and then do it. That is called cut umbilical cord milking. So the technique of the delayed cord clamping, position of the newborn during this time should be at least at or below the level of placenta. This is because we are thinking that gravity does play a role in this transfusion. And in normal vaginal delivery, so the baby should be placed on the mother's abdomen or between the legs. In case of cesarean, because we don't have that space, the newborn can be placed on the maternal abdomen or legs, or a surgeon can hold the baby, or assistant of the surgeon can hold the baby at close to the level of placenta until the umbilical cord is clamped. So the clinical situation where we can't do this, or we should not be doing it, is there could be some problems with the maternal or fetal. So the maternal problems could be a hemorrhage or a hemodynamic instability or both, or we have a placenta previa or a rupture placentae, then we cannot do it. The fetus or the neonate, when you need to have an immediate resuscitation, we will talk about it. Or when abruption has occurred, cord avulsion has occurred, or IUGR with abnormal cord Doppler evaluation, then we cannot do that. So the systematic review in 2018, where they looked into delayed versus early umbilical cord clamping for preterm infants. So there were 18 RCTs compared delayed versus early clamping in 2,834 infants. What was the result? The delayed cord clamping reduced the hospital mortality, and the RR is 0.68. 95% confidence interval is 0.52 to 0.90, and number needed to treat is 33. In 3 trials in 996 infants, less than 28 weeks, delayed cord clamping reduced the hospital mortality, and the number needed to treat is 20. This delayed cord clamping reduced the incidence of even low APGAR scoring at 1 minute, but that was not there at 5 minutes. However, it did not reduce the incidence of intubation for resuscitation, admission temperature, intermittent mandatory ventilation, intraventricular hemorrhage, brain injury, chronic lung disease, PDA, neck, late onset sepsis, or ROP. Delayed cord clamping increased the hematocrit by 2.73 percentage point, 1.94 to 3.52, reduced the proportion of infants having blood transfusion by 10%, which is a good number, 6 to 13%. And potential harms of delayed cord clamp included polycythemia and hyperbilirubinemia. So this we should know. So to conclude about the systematic reviews, it gives a high quality evidence that the delayed cord clamping reduced the hospital mortality, which supports the current guidelines recommending the delayed cord clamping in preterm infants. This review did not evaluate the cord milking, which also be of benefit. Now let's talk of umbilical cord milking, because it wasn't talked there, and it just means that you are milking or stripping, and usually you will do that less than 10 to 15 seconds. It was seen by Kotheria et al. And Upadhyay et al. And when you compare both the things, delayed cord clamping is passive, milking is active, time is 30 to 60 seconds. This is done within 20 seconds. Position of the baby doesn't matter in the milking. At delayed cord clamping, it should be at or below the introitus. Methods of umbilical cord milking is like with intact cord placenta, or you can cut it and then do it. So the amount of blood in the umbilical vein is usually 15 to 20 ml. And considering the 2/3 of the cord available for milking, that means it amounts to 7 to 10 ml. If milking is done 4 times, then it will give 30 to 40 ml, 7 into 4, 10 into 4. So that much amount of blood would be given. Now, immediate cord clamping will cause relative hypovolemia, and placental transfusion will cause euvolemia. So the blood pressure will be lower here and blood pressure will be more here. Vascular resistance is increased here, it is reduced here. RBC flow to the brain is less in the immediate clamping, it is more in the placental transfusion, and to the brain as well as gut. And renal blood flow is reduced here, it is increased here. Urine output is less in these babies, it's more in these babies. Sodium excretion is more, so you may have hyponatremia. Sodium excretion is less here, so you will have normal sodium. Decreased pulmonary vasodilatation, and here it is, pulmonary vasodilatation is increased. So benefits of delayed cord clamping, all placental transfusion is, immediate benefits is hemodynamic and hematological. Short-term benefits are hematological, and long-term benefits we have to look for. So hemodynamic benefits are higher systemic mean blood pressure. So in preterms tend to have a higher blood pressure in initial 4 hours, as seen by Kugelman, and term similar effects in initial hours. Higher circulating blood volume in preterms, it was seen that there was a difference of 74.4 ml per kg versus 62.7 ml per kg of blood volume. And in term, it contributed to be 20% of the baby volume. Immediate hemodynamic benefits in preterms are increased blood flow to the superior vena cava and to the right ventricular output and the right ventricular stroke volume in delayed cord clamping group. And this effect persisted for 48 hours. There was a higher cerebral oxygenation index, and which was seen at 4 hours, 69% versus 65%, and in 24 hours, 71% versus 68%. The reduced need for inotropic support, which is very important in the preterms. In a systematic review, they found that there was a less need for inotropic support. There was an improved cerebral blood flow and increased oxygen carrying capacity, increased pulmonary arterial pressure, and reduced ductal flow. The other hematological benefits are that there is a higher hematocrit and hemoglobin even in the early neonatal period. In the preterm, 17.46 versus 16.36, and hematocrit is 51 versus 47. In term, hemoglobin is 20 in 24 to 48 hours. The difference is 1.49. And also, not only that, there's an increased transfer of immunoglobulins and autologous stem cells. So it is something like stem cell therapy. In preterms, there is less IVH. 10 studies have shown that. And the RR is 1.86. Confidence interval is 1.28 to 2.71. Less NEC in 6 of the studies. RR is 1.64, 1.14 to 2.35, the confidence interval. And fewer transfusions for anemia. 7 trials showed that, including 392 infants, RR of 0.61, 0.46 to 0.8 is the CI. So both terms and preterms have higher hematocrit and hemoglobin even in the early neonatal period. There is a reduced incidence of late onset sepsis, especially in preterms and especially in the male infants. Long-term benefits are also there because the iron stores are improving and there is an improved more ferritin levels even at 6 months of age in both the term and the preterm babies. Anemia of infancy is less and motor functions have seemed to be better in less than 32 weeks. They looked into cognition and behavioral functions at 18 to 22 months and they found to be a better. There were fine motor activities was better. Social domain scores at 4 years was better, especially in the boys who received the delayed cord clamping. But what are the potential risks of delayed cord clamping? So the newborns may have too much of blood, so polycythemia may be there. They may be subjected to low temperature for a longer period and hypothermia may be there. Hyperviscosity may be there and hyperbilirubinemia requiring phototherapy may be also more. And that's seen 2.74% and 4.36% is the difference. And also TTNB might be more in these babies. What could be the maternal side effects? There are none. They are not associated with PPH or increased blood loss at delivery. And there was no requirement of the blood transfusion in these moms. So the recommendation by different organizations have said that European Association of Perinatal Medicine and the Canadian Society of Obstetrician and Gynecologists and the International Liaison Committee on Resuscitation said 30 to 60 seconds in both term and preterm babies, delayed cord clamping should be done who do not require resuscitation. WHO recommends umbilical cord should not be clamped earlier than 1 minute after birth in term and preterms both who do not require positive pressure ventilation. ACOG guideline in 2017 said delay umbilical cord clamping for at least 30 to 60 seconds after birth in a vigorous term and preterm infants. And Royal College of Obs and Gynae also stated 2 minutes of delayed cord clamping. American Academy of Pediatrics suggests 30 to 60 seconds of delayed cord clamping in term and preterm babies. So those who we are not able to do delayed cord clamping, is umbilical cord milking an alternative to delayed cord clamping? So the benefits are there. However, in the umbilical cord milking in intact cord, the immediate hemodynamic benefits are stabilization of the blood pressure. It stabilizes the blood pressure and the heart rate during the initial hours of life. And preterms have shown to have improved blood pressure over first 15 hours of life. So hemoglobin and hematocrit were also seen to be better if we are doing the umbilical cord milking. 22% was the hematocrit as compared to 45% in those we were doing milking. And terms also, the mean hemoglobin and hematocrit was significantly higher. And what you do, if you cut the cord and then do the milking, so you take a 25 to 30 centimeter of segment of cord and then on the warmer, you can untwist the cord and milk the cord by 2 to 3 times, 10 centimeter per second before clamping. And this may give a similar placental transfusion as non-cut milking. So the cut umbilical cord milking, the effects are similar to delayed cord clamping. The blood pressure remains significantly higher at 30 minutes, 12 hours, and 48 hours. Hemoglobin and hematocrit was also higher at 12 hours of age in the cut umbilical cord milking. And also it was higher till 6 weeks. There was no significant difference in polycythemia, serum bilirubin, and need of phototherapy as seen by Upadhyay et al. And ACOG 2013. It did not affect the cerebral blood flow dynamics during 48 hours of life. So combo plan, delayed cord clamping versus intact umbilical cord milking versus cord cut and umbilical cord milking. So Upadhyay et al., they had combined delayed cord clamping of 90 seconds with cut umbilical cord milking, and they found it to be significant in improving immediate hematological outcomes in first 30 minutes up to 48 hours. And hemodynamic variables were similar. So if baby is compromised, what to do? There might be a problem that you may be not able to do the resuscitation. However, if we continue the placental gas exchange and a placental transfusion, then it will lead to beneficial cardiovascular changes because pulmonary blood flow will be established better. And this will maintain a mean arterial pressure during the initial hours. It will maintain the venous return and cardiac output, and this may help to avoid adding an hypovolemic ischemic insult to an already asphyxiated infant, which will lead to inflammatory cascades, hypoxic ischemic encephalopathy, seizures, and death. So it's very, very beneficial. So the current recommendation during resuscitation is neonatal resuscitation guidelines are neutral as far as on ventilation before cord is clamped, and although they do not state the ventilation is a priority, ILCOT 2015, NRP 2016, there is not enough evidence to make a definitive recommendation whether umbilical cord clamping should be delayed in a newborn who are not vigorous, and there is an insufficient evidence to recommend an optimal timing of cord clamping in a compromised newborn, although as we saw that in a theoretical ground, the depressed infant might receive a greater benefit from delayed cord clamping. So what we should do, we can do a cord milking as an advantage on these babies who are unstable for 30 to 60 seconds, and umbilical cord milking can be preferred in a low resource setting, it will provide a placental transfusion without a delay. This can be done in 50 to 20 seconds, equivalent to the time it takes for intact cord clamping. So there were Indian trials which also looked into this. So what we need is transfuse. Tell the team what you plan to do, timeout. Request supplies 2 warm sterile towel. Assign roles. Note the time of the birth. Start the timer. Fetal transfusion period, announce time every 15 seconds. And stimulate the baby. Stop and clamp the cord and evaluate the baby. So this is a simple placental transfusion protocol that can be followed in the delivery room. So the baby says, please take care good of me and I'm your future. Thank you very much.